guys, I'm Dhvani.
My name is Frank. Jordan.
Sara.
McKayla.
Megan. And this is Chapter 18, Medicare and Medicaid, and our case is about Helen. Helen is a retired bank teller, 67 years of age, who has recently afflicted with a serious illness. After spending 10 days in the hospital, she spent 4 weeks in a skilled nursing facility before being discharged to her home. During her recuperation, Helen often reflected on how lucky she was to be enrolled in Medicare. Because of her limited income, it was reassuring to know that Medicare would take care of her substantial health care expenses. Helen was shocked, however, when she began receiving bills that Medicare did not pay. Adding up the bills from the hospital, skilled nursing facility, pharmacy, and her physician, she owed money more than $2,500. Helen could not understand how she could owe so much money when she had health insurance through Medicare. Medicare has been divided into several parts A, B, C, and D.
Medicare Part A covers inpatient care, including care received while in a hospital, skilled nursing facility, limited home health services, and hospice care. Most people are automatically eligible for Medicare Part A at the age of 65 if they are collecting Social Security. People may qualify for Medicare Part A before the age of 65 if they have a disability, end-stage renal disease, or amyotrophic lateral sclerosis, or also known as ALS. Medicare Part A covers hospital expenses that are critical to your inpatient care, such as semi-private rooms, meals, nursing services, medications that are part of your inpatient treatment. Medicare Part A also covers other services such as inpatient rehabilitation facilities, long-term care hospitals, mental health care, and acute care hospitals. Medicare Part A benefits for home health care services are covered when deemed medically necessary and ordered by your doctor. Home health care services may include part-time skilled nursing care, physical therapy, occupational therapy, social services, and part-time health care aides. Medicare Part A does not cover 24-hour home care, meals, or homemaker services. Medicare Part A benefit for nursing home care includes covered skilled nursing care at a Medicare certified facility. Specifically, Medicare will cover a semi-private room, meals, skilled nursing services, rehabilitation services, social services, and medications and medical supplies and equipment received in the skilled nursing facility, ambulance transportation, and dietary counseling. Medicare Part A will pay the full cost of days 1 to 20 in a skilled nursing facility if you meet the 3-day inpatient stay requirement. Days 21 to 100, Medicare pays all but the daily coinsurance. After 100 days, Medicare provides no coverage after the initial 100 days. Medicare Part A covers hospice care that is eligible to patients who are diagnosed by a certified doctor to have a terminal illness with an estimated 6 months or less to live. The goal of hospice care is to relieve pain and make sure patients are as comfortable as possible. Overall, Medicare Part A is a vital part of the inpatient medical coverage that helps cover the cost of proper medical care.
Now on to Part B. Part B covers services provided by physicians in a wide variety of settings, including hospitals, physicians' offices, nursing homes, and patients' homes. Other services covered under Part B include but are not limited to outpatient hospital services, x-rays and laboratory tests, and durable medical equipment. A variety of other preventive services covered under Part B include but are not limited to diabetes screening and supplies, mammograms, and pap tests. Services not covered by Medicare Part B include but are not limited to routine physical examinations, routine vision and hearing tests, routine dental care, and homemaker services. Each year, Medicare patients pay a deductible for Part B services. After that deductible has been met, Medicare typically pays 80% of the approved charge for most services. The patient is responsible for paying the other 20% of approved charges and may be financially responsible for the difference between Medicare's approved charge and the provider's actual charge, depending on whether the provider accepts assignment. When A provider accepts assignment, it means that his or her actual charge will be equal to Medicare's approved charge. In such cases, Medicare patients are assured that they will be billed for only 20% of the approved charge. However, when patients receive services from providers who do not accept assignment, they can also be billed for the difference between actual and approved charges.
Part C of the Medicare program is known as Medicare Advantage. It expands beneficiaries' ability to participate in a wide variety of private health plans, including health maintenance organizations and preferred provider organizations. Managed care innovations that might have been successful in constraining healthcare costs in the private sector is believed to be the one way to control Medicare spending. To help maintain and improve services, Medicare encourages enrollees to obtain services through managed care organizations. The level of services provided to older patients is improved, and it helps to keep costs under control. Even though it's not required to do so, many enrollees take advantage of this, and it has increased the number of people in HMOs tremendously to almost 11 million people today. From 1895 to 1997, the only option for Medicare enrollees was the managed care option. In 1997, the Balanced Budget Act was passed. This new Part C expanded the delivery of services and provided options. These include PPOs and other types of plans. By 2015, 31% of Medicare beneficiaries were enrolled in some type of Advantage plan. These Medicare Advantage plans are required to provide benefits similar to those received on Medicare. If a plan is less costly than Medicare payments, the plans are required to pass those savings to beneficiaries by providing lower premiums, reducing cost sharing, or another form of benefit. By 2010, 90% of Advantage plans provided no cost sharing for preventative services and unlimited days in inpatient hospital care, and about 80% limit out-of-pocket spending. On average, it saves each enrollee about $79 per month.
Medicare Part D. Under the Part D standard benefits, beneficiaries pay a $360 deductible for prescription drugs, after which they pay 25% of the next $2,950 of drug costs. Thus, in total, patients pay $1,098 of the first $3,310 in prescription drug costs. At that point, there is a coverage gap, or a donut hole, in Medicare coverage that requires Medicare patients to pay a larger share of their total drug costs until they have paid a total of $4,850 in prescription drug costs out of their own pockets. After beneficiaries have spent this amount out of pocket, Medicare's catastrophic coverage kicks in. Beneficiaries then pay the greater of either a 5% coinsurance charge or co-payments of $2.95 for generic or preferred multi-source drugs and $7.40 for other drugs. Because formularies and cost containment strategies differ among drug plans, as so premiums and cost sharing requirements, patients' actual out-of-pocket expenses can vary considerably among plans, and it is important for Medicare beneficiaries to shop wisely when selecting plans. Medicare provides a variety of subsidies for low-income beneficiaries who enroll in Part D. For example, individuals with both Medicare and Medicaid, those who are dual eligible, pay no monthly premium or deductible, and their co-payments for prescription drugs are fairly nominal and vary according to income, with those for generic drugs being less than for brand name drugs. Dual eligibles in nursing homes have no co-payments.
So in conclusion, what does all this mean for our case and with Helen? Since Helen is over 65 years of age, she is eligible to receive Medicare. Part A of Medicare will cover most of her inpatient needs. She will have her initial 10 days stay at the hospital, as well as the first 20 days at the specialized nursing facility covered completely. Since Helen was there for 4 weeks, the final 8 days of her 28-day stay will be partially covered by Medicare Part A. Part D of Medicare, again, only covers part of the drug costs for the patient. Since Helen has likely been receiving drugs from the pharmacy after her stay in the hospital and specialized nursing facility, some of the accumulated costs from her illness are a result of Medicare only paying approximately 25% of the drug costs after her stay. Part B is somewhat similar to Part D in the fact that patients do not receive full coverage in the cost for the services. Medicare only covers about 80% of the services, such as laboratory tests and x-rays. If Helen received any of these services during her stay, she would again have some additional costs to her bill. Finally, Part C, or Medicare Advantage, gives Helen the ability to join another private care health plan to help cover what Medicare does not. Patients are encouraged to join another prepaid health service to supplement what they receive from Medicare. It is most likely Helen did not understand Part C of Medicare, and because of this, she does not have an additional health plan to help her cover the extra $2,500 she accumulated during her hospital and special nursing facility stay.
This concludes our case scenario. Thank you.